there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. And I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which you may find useful in your line of duty. Welcome to part 70 of our pharmacotherapy MCQ series, which measures in toxicology. And our first question reads, KHR, a middle-aged patient, was admitted to your med-surg ward. He is hyperkalemic after an apparent digoxin overdose. He fails to improve despite the administration of Digibind at the appropriate or recommended dose. So my question to you is, which course of action listed below would be the next best option in KHR's case or management? Would you consider administering sodium bicarbonate? Would you consider using lipid emulsion therapy? Would you consider infusing insulin plus dextrose? Or would you consider administering IV calcium chloride? I'll give you 10 seconds to choose the correct answer. I would opt to infuse insulin and dextrose. Now, insulin plus dextrose would be the best choice for the treatment of hyperkalemia in digoxin toxicity. Calcium administration is controversial due to the case of what we call stone heart, which was mainly observed in animal studies with rapid rise in calcium levels. However, it is okay to give it if the patient is bradycardic and has a wide complex rhythm, and if it isn't known if the patient is on digoxin or not, when there is uncertainty of what caused the toxicity. Now, lipid emulsion therapy may be of benefit in the management of calcium channel blocker toxicity or in the beta blocker toxicity, not in the case of digoxin toxicity. And sodium bicarbonate, which is alternative A, may be used if the patient is hyperkalemic and has a wide QRS interval, but it isn't as effective as insulin plus dextrose. So I would settle for alternative C. Let's move to the next question, please. The next question reads, Mr. FKO, a 24-year-old male patient, presents to your accident and emergency department. He is depressed and he has a history of alcohol abuse. He ingested 62 tablets of paracetamol, acetaminophen 500 milligrams, in an attempt to commit suicide. At your A&D department, he is on suicidal precautions. Your team is cautious. Now, according to the Rumac Matthew nomogram, when should the first acetaminophen level be checked and plotted? Is it at the 8-hour mark from the time of ingestion, or is it 4 hours from the time of ingestion, or is it 10 hours from the time of ingestion, or should you do it 2 hours from the time of ingestion? I'll give you 10 seconds to choose the correct answer. Ideally, it should be drawn 4 hours from the time of ingestion. Now, the initial assessment of paracetamol or acetaminophen levels from the time of ingestion on the Rumac Matthew nomogram is 4 hours according to literature. Unfortunately, the clinician would need to have a clear evidence of the timing of ingestion for this tool to be utilized appropriately and effectively. Now, if the suicidal patient refuses to provide this information, or if he has an elevated mental state due to co-ingestion of other substances, then the clinician is faced with assessing for levels of paracetamol at that time to avoid missing toxic paracetamol levels, which could already be causing organ damage, majorly hepatotoxicity to be specific. I would just like to emphasize that the Rumac Matthew nomogram was developed to guide clinicians on when the risk of hepatotoxicity is high enough and warrants initiation of N-acetylcysteine treatment. That's just for your information. Let's move to the next question. And it reads, Master TTT, a 4-year-old boy, is rushed to the accident and emergency department by an ambulance, and he has no nausea, he's not vomiting. His mother called the ambulance services. Immediately he ingested a handful of glucotrol or glipizide tablets, the sugar-coated ones, mistaking them for candy. They looked colorful and sweet in his sight. Now 40 minutes have elapsed since she called the ambulance services, and TTT was rushed to the accident and emergency. He is awake and alert. So my question to you is, which treatment option listed below would be the most appropriate initial treatment for Master TTT now? Would you choose to administer diazoxide, activated charcoal, octreotide, or glucagon? I'll give you 10 seconds to choose the correct antidote. So I would use activated charcoal in this case. Now, activated charcoal would be the most appropriate initial treatment for this accidental known overdose with glipizide, which is marketed as glucotrol, especially when the patient presents within an hour of ingestion, or if the patient isn't having nausea or is not vomiting and appears to be able to protect their airway. And the goal in this case is to prevent or reduce or minimize the degree of absorption of glipizide. Now, diazoxide alternative A, which is marketed as proglycem, is an oral agent typically used to treat insulinomas, but it can also be used in refractory cases of sulfonyl urea toxicity, so it would not be the best choice in this case. And I would like to add that if no IV access is available to enable us administer IV dextrose, then glucagon can be considered. So it's not first line, but it can be considered if we are not able to administer our first choice because of lack of IV access. Now, alternative C, octreotide, which is marketed as sandostatin, is a subcutaneous semi-synthetic long-acting analog of somatostatin, and it blocks insulin secretion from the beta cells, so it would not be the best option here. So I would like to remind you that activated charcoal should only be used within 1 hour of confirmed sulfonyl urea ingestion, and should also be considered if the airway can be protected, if the patient isn't vomiting or nauseous, and when there is no evidence of GI obstruction or any risk of perforation. So be careful, put into consideration all those facts before you settle for activated charcoal to absorb this medication. Let's move to the next question, please. The next question reads, Miss JOO, a 14-year-old girl weighing 56 kilos, presents to the accident and emergency department after ingesting approximately 50 tabs of acetaminophen 500 milligrams 5 hours ago. On plotting her acetaminophen level on the Rumac Matthew nomogram, it indicates probable hepatic toxicity. Miss JOO is awake and alert, and your emergency team initiates N-acetylcysteine. My question to you is, which of the statements listed below most accurately describes the mechanism of action of N-acetylcysteine in acetaminophen toxicity? Does it replenish glutathione? Does it induce glucuronidation pathway? Does it block NEET-PG formation? Or does it inhibit CYP2E1? I'll give you 10 seconds to choose the correct answer. That it replenishes glutathione. Now, N-acetylcysteine is the most effective when used within 8 hours of paracetamol overdose. Given an accurate or dependable story, the amount of paracetamol ingested in this particular lady's case exceeds the 150 milligram per kilo toxic dose of ingestion. From my quick arithmetic, and the strength of the tablets, from what we are told, is 500 milligrams each. So this lady ingested a total of 25,000 milligrams of paracetamol, acetaminophen. Now, considering her weight, which was 56 kilos, she took 446.43 milligrams per kilo. So in such a scenario, it would be highly recommended to simply start treatment to avoid further damage of the liver. Now, N-acetylcysteine is the antidote of paracetamol overdose, and it reduces hepatotoxicity, especially when it is known that the total amount ingested exceeds, as I said, 150 milligrams per kilo over a single ingestion, or 7.5 grams over a 4-hour period of time. That's just a by the way, and all those many words justify why A, replenishes glutathione, would be the best explanation of its mechanism of action. Let's move to the next question, please. And it reads, which of the statements listed below best explains why hepatic toxicity is worse with acetaminophen overdose in chronic alcoholics? Is it true that there is upregulation of CYP2E1, or is it due to macrocytic anemia, or is it due to low glutathione levels, or is it due to the inhibition of alcohol dehydrogenase? I'll give you 10 seconds to choose the correct answer. So both A and C are correct. This the issue of upregulation of CYP2E1 and low glutathione levels. Now, chronic alcoholics have upregulation of CYP2E1, and they also have low glutathione levels, which can increase the risk of hepatotoxicity from paracetamol or acetaminophen ingestion. Now, the shunting of paracetamol through the CYP2E1 metabolism is the primary route for the generation of the toxic metabolites, which we call NEET-PG. NEET-PG in full is N-acetyl para-benzoquinone imine. I-M-I-N-E. N-acetyl P-benzoquinone imine. Now, macrocytic anemia, alternative B, can be seen with chronic alcoholism, and that's majorly due to, in my opinion, vitamin B12 deficiency. But it doesn't increase the risk of acetaminophen toxicity at all. Now the concern with paracetamol overdose is oversaturating phase 2 metabolic pathways, resulting in the production of NAPK via the CYP2E pathway, and this depletes glutathione, causing oxidative damage of the hepatocytes. Now I'd like just to remind you that fomepizole or antizole is a well-known inhibitor of alcohol dehydrogenase, and is used to prevent the metabolism of ethylene glycol, which is antifreeze, and methanol into their respective acids that cause toxicity when ingested. So alternative D does not apply. It's not the correct answer in this particular case. Let's move to the next slide, please. And the question reads, which of the phases of nodal action potential listed below does digoxin affect? Does it affect phase 2, 0, 4, or 1? I'll give you 10 seconds to choose the correct answer. So digoxin increases phase 4 depolarizations. That makes C the correct answer. It actually increases the resting membrane potential by blocking the sodium potassium ATPase pump, causing a rise in intracellular sodium. Now beta blockers and the calcium channel blockers, if I remember physiology well, affect phase 4 by reducing the movement of sodium inside the cell, and they also depress automaticity of the sinoatrial node and the AV node. Digoxin toxicity increases the risk of dysrhythmias due to increased resting membrane potential and increased automaticity, and even electrolyte changes which may occur. Just as a by the way, let's move to the next question, please. And it reads, Mrs. PWW, a 78-year-old Kenyan woman, calls your accident at the emergency department seeking help after she accidentally took twice her daily prescribed digoxin dose due to an incorrect refilling of her pill box by her spouse. My question to you is, in this unfortunate scenario, which of the counseling points listed below would be the most appropriate for Mrs. PWW now? Would you advise her to call an ambulance immediately? Or would you advise her to watch for diarrhea, visual disturbances, and any confusion that may ensue? Or would you advise her to skip her tomorrow's dose and then resume normal dosing thereafter? Or would you advise her to induce vomiting using syrup of ipecac? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. I would advise this lady to watch for diarrhea, visual disturbances, and confusion. And we know that acute digoxin toxicity can cause nausea, vomiting, abdominal pain, and this can occur within a few hours of ingestion. Now, other signs of acute toxicity may also include, if I remember well, lethargy, confusion, and even weakness in some patients. Now, if Mrs. PWW doesn't manifest these signs and symptoms within several hours of ingestion, severe acute poisoning with these alkaloids like digoxin is unlikely. Now, single injections of less than 2 milligrams of digoxin are unlikely to cause significant toxicity. Therefore, calling an ambulance at this point, in my opinion, isn't necessary. That makes alternative A wrong. Now, since this isn't a life-threatening ingestion, inducing vomiting as stated in alternative D, is generally not acceptable in practice, and it isn't the appropriate option for Madam PWW's case. Now, while skipping the dose would likely be reasonable, it isn't the most appropriate action or course of action in PWW's case at this time. Now, a clear history of the patient's story and an understanding of toxicokinetics of digoxin is necessary to be able to determine which patient requires general supportive care and those who require an antidote such as the Digifib or the Digibind. Now, the classic description of visual disturbances, that is changes in color vision, particularly the yellow halos as they describe them around lights from digoxin toxicity, often results from chronic overdose. So that's just by the way. And I would like to add that while digoxin levels may assist in identifying toxicity, the serum potassium levels, I think in my opinion, would be the best predictor of morbidity and mortality in cases of digoxin toxicity or overdose. Now, common causes of acute or chronic digoxin toxicity are a result of patients who experience a transient decrease in renal function resulting in digoxin accumulation, or even drug-drug interactions. Those two can cause toxicity, chronic toxicity to be specific. Let's move to the next question, please. And it reads, Mrs. JKG, a 46-year-old female patient, chronically undergoes dialysis at your renal unit on Mondays, Wednesdays, and Fridays. Today, she presents to your accident and emergency department complaining of severe abdominal pain. She is possibly septic. As the clinical pharmacist attached to the nephrology unit, you review her medication list and you notice she receives chronic desferoxamine for hemochromatosis. So my question to you is, which of the pathogens listed below would you consider as a possible etiology for Madam JKG's sepsis? Would it be Francisella tularensis? Would it be Cryptococcus neoformans? Would it be Histoplasma capsulatum? Would it be Yersinia enterocolitica? I'll give you 10 seconds to choose the correct answer. So Yersinia it would be. Yersinia enterocolitica requires iron as a factor or a growth factor to be specific, but it lacks the siderophore required to transport the iron intracellularly. Now desferoxamine acts as a siderophore and it permits iron absorption to Yersinia enterocolitica, thus allowing for bacterial growth. Now Yersinia infection is an adverse event of desferoxamine therapy because of that explanation I've just offered, and it can be treated with fluoroquinolone or even ceftriaxone administered IV. Now other adverse events of desferoxamine include ARDS. It can also cause hypotension and even acute renal failure. So when using it in management of iron overdose, be very cautious, be very careful. Now sufficient renal function is required for chelation therapy with desferoxamine to be used. Otherwise hemodialysis must be considered if there is a case of iron overload. Just as a by the way, let's move to the next slide, please. The next question reads, which of the physiological actions listed below isn't a rationale for the use of beta blockers in patients with low cardiac output heart failure? Is it reduction in remodeling of the myocardium? Is it decrease in cardiac output? Is it increased depolarization? Or is it protection against sudden cardiac death? I'll give you 10 seconds to choose the correct answer. So both answers B and C are correct. It does decrease cardiac output and also increases depolarization. Now, beta blockers decrease chronotropy, that is heart rate, and they also reduce inotropy, which is the force of contraction of the ventricular myocardium, and therefore that leads to a reduction in cardiac output. Now, since depolarization is reflective of ventricular contraction, beta blockers decrease or inhibit depolarization of the ventricular myocardium, and they don't increase it as case A may suggest. Now, diltiazem and verapamil don't reduce remodeling of the myocardium, nor do they protect against sudden cardiac death in heart failure patients. So that makes alternatives A and D wrong. I would just like to add that beta blockers provide protection against sudden cardiac death, and they reduce remodeling of the myocardium in patients with heart failure. Now, blood pressure is can be calculated as cardiac output times systemic vascular resistance, just for your information, and cardiac output is heart rate times stroke volume, where stroke volume is made up of preload, inotropy, and afterload. So let's move to the next slide, and it reads, which of the agents listed below can be used as a chelating agent in copper toxicity or copper poisoning? Is it saxima, N-acetylcysteine, D-penicillamine, or DMPS? I'll give you 10 seconds to choose the correct answer. So both answers A and C are correct. I would just like to start by saying that DMPS can further copper-induced redox cycling and even potentiate hemolysis. And D-penicillamine and saxima are effective chelating agents for copper. It would be the best options in this case, while N-acetylcysteine may benefit patients with hepatic injury due to copper, but it isn't a chelating agent, so that makes it a wrong option. I would like to add that D-penicillamine is a metabolite of penicillin, but it is not used for antimicrobial therapy. It's used as a chelator. Its brand name is cuprimine, C-U-P-R-I-M-I-N-E, and it's used for copper chelation, to be specific. It is used in copper-induced hemolysis in Wilson's disease and copper-induced methemoglobinemia resistant to the treatment with methylene blue. That's just a by the way. Let's move to the next question, please. And it reads, JRM, a female patient, is rushed to your accident and emergency department. JRM is vomiting but conscious with no GI symptoms. She was found by her mother half an hour ago after swallowing an unlabeled bottle full of tablets. Now, which of the scenarios listed below wouldn't be an indication for the use of activated charcoal in Madam JRM's management? Would it be no evidence of GI obstruction? Would it be vomiting? Would it be confirmed ingestion of an agent within 1 hour? Or would it be airway can be protected? I'll give you 10 seconds to choose the correct answer. So B would be the best answer. Vomiting it is. Now, if activated charcoal were administered, vomiting, in my opinion, increases the risk of aspiration of activated charcoal into the lungs, which could lead to some deleterious effects. Now, activated charcoal should only be used within 1 hour of confirmed ingestion of any agent if the airway can be protected and if the patient isn't actively vomiting or nauseous, and also if there is no evidence of GI obstruction or any risk of perforation. So be very careful before you opt to use activated charcoal. Now, I would like to add that we should not give sorbitol containing activated charcoal, as this can increase the risk of vomiting. Now, whole bowel irrigation is indicated for the ingestion of long-acting or sustained release formulations because they take long to disintegrate in the stomach. Now, whole bowel irrigation and activated charcoal shouldn't be used together, since the whole bowel irrigation will decrease the efficacy of activated charcoal, increases the rate of emptying of the gut, so the charcoal will be emptied before it absorbs whatever you want to get rid of. So don't use the two together. Now, avoid the use of whole bowel irrigation in the presence of ileus, bowel obstruction, and even toxic megacolon. It would be very risky and dangerous in those circumstances. So all those many words would make me settle for B, vomiting. So, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing it and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration. And I would like to say that I look forward to interacting with you in the next video. Thank you very much.